Hello, everybody. This is Jeanne E. Poole, Editor-in-Chief of the Heart Rhythm O2 Journal, and this is the August 2026 podcast. Comparative analysis of hemolysis incidence across 3 different pulsed field ablation systems by Dr. Hiroyuki Miyazawa. The first key finding from this study is that intravascular hemolysis occurs frequently after pulsed field ablation, with greater severity than radiofrequency ablation and no changes observed in non-ablation procedures. Amongst 3 commercially available single-shot PFA systems, Farapulse was associated with the greatest degree of hemolysis and myocardial injury, whereas Pulse Select showed the least changes. The degree of hemolysis was significantly associated with procedural exposure, with a clear correlation between the number of PFA applications and haptoglobin depletion across all systems. Next, the application ratio and body mass index were independent predictors of hemolysis, suggesting both procedural and patient-related determinants. Finally, although hemolysis was common, clinically significant renal dysfunction was rare, indicating that careful procedural optimization, particularly minimizing unnecessary applications, may mitigate risk. Aortic root-based ablation of parahysteine atrial tachycardia, acute and long-term outcomes from a consecutive series by Dr. Miguel Amores-Luque and colleagues. The first key finding is that parahysteine atrial tachycardias represented a substantial portion, or 18.5%, of focal atrial tachycardias undergoing ablation in the author's cohort, suggesting that the origin may be more frequent than previously reported in some series. Second, a preferential non-coronary cusp approach for PHAT ablation was associated with a very high acute success rate and favorable midterm arrhythmia-free survival, with no significant atrial ventricular conduction disturbances. Next, the earliest atrial activation times recorded at the non-coronary cusp and the parahysteine right atrium were similar, with a small but statistically significant difference favoring the non-coronary cusp. PHAT was characterized by a significantly shorter and frequently low-voltage P-wave during tachycardia compared with sinus rhythm, which may raise suspicion of parahysteine origin. And then finally, a structured stepwise mapping strategy prioritizing the non-coronary cusp may reduce the risk of atrial ventricular block compared with right atrial septal ablation. Efficacy and safety of pulsed field ablation for cable tricuspid isthmus-dependent atrial flutter, a meta-analysis based on real-world evidence by Dr. Lai Liu and colleagues. First key finding is that real-world evidence indicates that pulsed field ablation is a highly effective method for cable tricuspid isthmus ablation, achieving a 99.4% short-term success rate with a highly efficient average ablation time of less than 9 minutes. Second, PFA exhibits an excellent safety profile for CTI ablation with 0% pooled incidences of catastrophic complications and permanent atrial ventricular block across 656 patients. And finally, the overall risk of transient intraprocedural right coronary artery spasm is low, 2%, and can be significantly mitigated by implementing a prophylactic high-dose, greater than 1 milligram intravenous nitroglycerin regimen. Versatility of the novel balloon and basket pulsed field ablation catheter, pulmonary vein isolation and beyond by Dr. Raheen Wahidi and colleagues. The first key finding is that initial experience with the novel balloon in basket pulsed field ablation, or BIB-PFA, catheter suggests broad procedural versatility beyond pulmonary vein isolation, enabling effective mapping and ablation of atrial tachycardia, atrial flutter, and atrial substrate modification using a single device approach. Second, all procedures were performed in deep sedation without conversion to general anesthesia. And finally, no procedural complications were observed overall. Notably, no electrocardiogram changes occurred during or after cable tricuspid isthmus ablation performed with BIP-PFA catheter, despite minimal or absent prophylactic nitroglycerin administration. Feasibility, safety, and efficacy of epicardial CO2 insufflation to facilitate epicardial access for VT ablation. A systematic review and meta-analysis by Dr. Sada Alawani and colleagues. First key finding is that epicardial carbon dioxide insufflation assisted epicardial access demonstrated a high procedural success rate of 94%. Major complications were uncommon, with low rates of pericarditis, significant bleeding of equal or greater than 80 milliliters, 5%, and mortality, 1%. Epicardial CO2 inflation enabled the identification of pericardial adhesions, 7%, supporting safer puncture and catheter manipulation. And finally, limited comparative data showed no significant differences in success or procedural duration versus conventional dry EA. Larger prospective multi-center comparative studies are needed to define epicardial carbon dioxide insufflation as assisted epicardial ablation potential advantages over conventional epicardial access. Vascular closure devices and electrophysiology procedures, systematic review and meta-analysis by Dr. Leonardo Knjink and colleagues. First key finding. In the author's meta-analysis, vascular closure devices reduced the rate of hematoma and total vascular complications. Second, time to ambulation, discharge, and disposition were also lower in the vascular closure arm. Third, the cost-effectiveness of vascular closure devices remains uncertain. And finally, further head-to-head trials comparing different vascular closure devices are needed. Late device-related thrombus after left atrial appendage closure following early antithrombotic discontinuation, the paradox of complete sealing. First key finding is device-related thrombus was detected in 5.8% of patients with evaluable 45-day imaging after left atrial appendage closure, including 2 early and 4 late and very late events. Late and very late device-related thrombus occurred exclusively in patients who discontinued all antithrombotic therapy at 45 days, whereas no events were observed in patients who remained on therapy at 45 days. Next, device-related thrombus clustered in a high stasis phenotype characterized by deeper implantation and baseline appendage stasis features, such as dense, spontaneous echo contrast and low left atrial appendage emptying velocity. Complete sealing, peri-device leak 0 alone, was insufficient to ensure safety for early full antithrombotic withdrawal and selected high stasis anatomies supporting physiology-guided de-escalation strategies. Atrial fibrillation ablation in patients with hypertrophic cardiomyopathy, findings and outcomes of repeat ablation procedures by Dr. Jose F. de Mello, Jr. and colleagues. First key finding is that the outcomes of repeat atrial fibrillation ablation in patients with hypertrophic cardiomyopathy are comparable to patients without HCM, lending support to repeat ablation as a management option for patients with HCM. Second, pulmonary vein reconnection is a common finding in patients with HCM, undergoing repeat AF ablation, highlighting the importance of pulmonary vein isolation durability as a key determinant of AF ablation outcome in HCM. Finally, clinical predictors such as left atrial volume index and early AF recurrence, that is less than 6 weeks post-ablation, were associated with later AF occurrence in univariate analyses, but no clear predictors were identified in a multivariate analysis. The next paper is titled Pulsed Electric Field for Pulmonary Vein Isolation in Paroxysmal Atrial Fibrillation, a multicenter experience comparing pentaspline and lattice tip catheters by Dr. Alexandra Amorad and colleagues. First key finding is that lattice tip and pentaspline ablation catheters achieve very high and similar success rates for pulmonary vein isolation and 1-year arrhythmia-free survival, with no statistically significant differences. The lattice tip catheter was associated with longer procedural and dwelling times, but significantly shorter fluoroscopic time. And finally, both groups showed low and equivalent complication rates, including no major complications, indicating that both catheter types are similarly safe for first-time PVI in patients with paroxysmal atrial fibrillation. The title of the next paper is Pulmonary Vein to Ganglionated Plexi Distance, Predicts Cryoballoon Ganglionated Plexi Modification by Dr. Kenji Yamiji and colleagues. Key finding is that pulmonary vein ganglionated plexi distance was strongly associated with successful ganglionated plexi modification during cryoballoon ablation. Second, ganglionated plexi located close to the pulmonary vein left atrial junction were frequently modified by cryoballoon ablation, whereas those located farther from the junction were less likely to be modified. And finally, post-ablation voltage mapping showed high concordance with high-frequency stimulation in the validation subgroup, suggesting that it may provide an objective method for evaluating ganglionated plexi modification. Lead fragment characteristics and detection by radiographic imaging after heart transplant by Dr. Christian Bichard and colleagues. First key finding is that retained cardiac implantable electronic device lead fragments are common after orthotopic heart transplant, approximately 21%, and likely under-recognized, with most located in central veins, especially the innominate vein. Second, chest radiograph has limited diagnostic and reporting performance, approximately 79% sensitivity, only 37% reporting of visible fragments, with a substantial proportion of fragments only visible on computed tomography, although only identified in 65% of computer tomography reports. And finally, longer lead dwell time and dual coil implantable cardioverter defibrillator leads are associated with fragment retention. Refining left bundle branch block criteria for improved left bundle branch area pacing response in heart failure by Dr. Hao Huang and colleagues. First key finding is that amongst the 5 evaluated criteria, the Strauss definition demonstrated superior performance for long-term clinical outcomes. Second, Strauss criteria also performed better for the other endpoints, including QRS duration narrowing, left ventricular ejection fraction improvement, and short-term clinical outcomes. Third, time to notch slur in lead B5, B6 of equal to or greater than 60 milliseconds was also strongly and independently associated with outcomes among patients whose electrocardiogram was also classified as a left bundle branch block by the Strauss criteria. And finally, discordant T waves, regardless of left bundle branch block criteria, are an intrinsic adverse marker independent of the therapeutic effects of physiologic pacing. Healthcare utilization for premature ventricular complexes in acute settings by Dr. Jean-Jacques Nubiat and colleagues. First key finding is that among over 87.8 million healthcare encounters in California between 2016 and 2022, 0.27% were associated with a diagnosis of premature ventricular contractions, and 0.03% were primarily for PVCs. The proportion of encounters with a diagnosis of PVCs increased over time, from 0.19% in 2016 to 0.31% in 2022, with higher rates in men, older individuals, and white patients. Next, healthcare utilization specifically for PVCs as a primary diagnosis also increased significantly over the study period across all socio-demographic groups. And finally, the number of catheter ablations for PVCs nearly doubled between 2016 and 2022, with approximately 15% of patients undergoing ablation. Next paper is terbutaline for sinus node dysfunction after heart transplantation by Dr. Ursula de Filippis and colleagues. First key finding is that in this single-center study, less than 10% of heart transplant recipients required initiation of terbutaline for early sinus node dysfunction postoperatively. Next, amongst those started on terbutaline, there was a significant increase in heart rate and thick cardiac index after treatment initiation, although changes varied widely from individual to individual. Next, 50% of those initiated on terbutaline had sinus node recovery, defined as a heart rate of at least 90 beats per minute at drug discontinuation. And finally, only 2 patients required permanent pacemaker implantation early after transplantation. Device-related events do not alter long-term psychological distress after implantable cardioverter defibrillator implantation, a 24-month prospective cohort study by Dr. Marta Huntelaar and colleagues. First key finding is that psychological distress decreased significantly over the 24 months after implantable cardioverter defibrillator implantation. Second, although 1/3 of patients experienced device-related effects, these events were not associated with adverse long-term psychological outcomes. And finally, baseline depressive and anxiety symptoms were the strongest predictors of psychological distress at the 24-month follow-up. Finding risk stratification for primary prevention ICD therapy, insights from cardiac MRI in the DO-IT registry by Dr. Marta A.J. Becker and colleagues. First key finding is that in patients with reduced left ventricular function owing to ischemic or non-ischemic cardiomyopathy, who received guideline-directed therapy, clinical event rates remain low over a 4-year follow-up period. Second, contrary to previous reports, this study could not find a significant association between either the presence or the extent of late gadolinium enhancement and device therapy or survival in patients with ischemic or non-ischemic dilated cardiomyopathy and primary prevention implantable cardioverter defibrillator. And third, the underlying etiology of reduced left ventricular function determines characteristic changes on cardiac magnetic resonance imaging, leading to distinct predictors of adverse clinical outcomes. Limited benefit of half-normal versus normal saline irrigation for augmenting current delivery with open irrigated temperature-controlled ablation by Dr. Henry Huang and colleagues. First key finding is that lesion size was not increased by using half-normal saline irrigation during ablation with an open irrigated temperature-controlled catheter, or Q-DOT MICRO, which features embedded tip thermocouples, in contrast to the significant augmentation observed with power-controlled ablation. When using HNS with temperature-controlled systems that accurately measure tissue interface temperature, average power delivery is comparatively lower owing to enforcement of preset maximum temperature cutoffs. Third, the temperature regulation may provide safety benefits as evidenced by a trend toward reduced steam pop incidence with temperature control compared with power-controlled ablation using HNS. And finally, clinicians using modern temperature-controlled ablation systems with embedded temperature sensing should not expect larger lesions from HNS irrigation and should instead consider higher power settings when seeking to maximize lesion depth. Design and rationale of the pulse field ablation for post-infarction ventricular tachycardia. The ASCEND-VT pilot study by Dr. Jakub Srubeck and colleagues. The first key finding is that ASCEND-VT is a pilot trial that randomizes patients with ischemic cardiomyopathy and ventricular tachycardia to endocardial ablation using standard radiofrequency versus novel pulse field ablation catheter. Second, the intervention arm will use the new FARAPOINT focal pulsed field ablation catheter under the U.S. Food and Drug Administration's investigational device exemption. Third, the immediate procedural endpoint in all patients will be total elimination of abnormal electrograms, specifically late abnormal ventricular activity. Next, the trial's primary efficacy metric is the time needed to eliminate lavas in the two study arms. This will be tested for non-inferiority. And finally, additional efficacy and safety metrics will be assessed after the ablation and over the course of a 6-month follow-up period. Gut microbiota atrium axis. Microbiota metabolite-mediated regulation of the NLRP3 inflammasome in atrial fibrillation. Pathophysiological roles and therapeutic perspectives by Dr. Zhu Ling and Jiansheng Hu. First key finding is that gut microbial metabolites seem to regulate atrial fibrillation-relevant inflammation in a stage-specific manner through the NLR family pyrin domain containing 3 inflammasome. Second, lipopolysaccharide and indoxyl sulfate mainly support priming, whereas trimethylamine and oxide and selected bile acids are more closely linked to inflammasome assembly. 3. Short-chain fatty acids may counter both priming and assembly by strengthening barrier function and suppressing nuclear factor kappa B-related signaling. Next, current human evidence is largely associative, and many mechanistic links remain supported mainly by preclinical or non-atrial models. Finally, a stratified therapeutic framework can help separate established lifestyle strategies from exploratory metabolite targeting and inflammasome-directed interventions. Evaluation of the effect of hydroquinidine on ST segment in Brugada syndrome using 12-lead Holter monitoring by Dr. Catherine Chiswell and colleagues. First key finding is that hydroquinidine was associated with an increased burden of ST segment elevation compared with baseline. Second, the association was observed in patients with therapeutic HQ levels, but not in subtherapeutic patients. This suggests a degree of dose responsiveness, although more investigation is required to confirm this observation. And third, one patient developed repetitive, sustained episodes of monomorphic ventricular tachycardia on HQ therapy that were not observed during baseline monitoring. The title of the next paper is An Irregular Narrow QRS Tachycardia Mimicking Atrial Fibrillation, the Importance of Pre-Procedural Diagnosis in the Era of Pulsed Field Ablation. The key findings are first, supraventricular tachycardia involving dual atrial ventricular nodal pathways may appear irregular owing to switching between conduction pathways. However, unlike atrial fibrillation, typically exhibits a regularly irregular pattern. Second, dual atrial ventricular nodal physiology alone does not warrant ablation. Treatment decisions should be guided by the documented tachycardia mechanism. And third, in the era of pulsed field ablation, ablation procedures for atrial fibrillation often involve minimal or no electrophysiologic testing, making accurate pre-procedural diagnosis critically important. Focal pulsed field posterior wall isolation with a novel focal linear catheter during redo atrial arrhythmia ablation. The first key finding is that focal pulsed field ablation catheters can facilitate the efficient creation of linear lesion sets in atrial fibrillation ablation. Second, posterior wall isolation can be achieved using sequential multi-electrode PFA applications with limited lesion numbers. Next, lesion spacing and predictable lesion depth are important determinants of effective PWI. And finally, the use of focal PFA technology for PWI remains off-label and requires further investigation. The next paper is the third Fellows Case Report. The title is Reversible Verapamil-Induced Atrial Pacing and Sensing Failure in an Atrial Leadless Pacemaker by Dr. Hiroshi Minoji and colleagues. The key findings are, first, verapamil may suppress atrial myocardial excitability and markedly reduce P-wave amplitude, particularly in patients with depressed atrial myocardium. Second, marked attenuation of intrinsic atrial signals may result in undersensing and loss of capture in patients requiring atrial pacing. And third, when pacing failure occurs immediately after verapamil administration, drug-induced suppression of atrial excitability should be suspected. Long-term continuous rhythm monitoring in patients with mitral annular disjunction by Dr. Fatima Ezzedine and colleagues. The first key finding is that continuous rhythm monitoring in patients with mitral annular disjunction identified a substantial burden of atrial and ventricular arrhythmias. Second, arrhythmia detection in this cohort translated into significant clinical action, with 12.5% of patients undergoing implantable cardioverter defibrillator implantation and 9% of patients undergoing catheter ablation. Third, further prospective studies are warranted to define which patients with mitral annular disjunction derive the greatest benefit from continuous surveillance and early intervention. Procedural efficiency versus clinical outcomes in persistent atrial fibrillation ablation, a population-level trade-off by Dr. Laurent Fauchier and colleagues. First key finding is that in a capacity-constrained model, 1000 electrophysiology laboratory, a pulmonary vein isolation, or PVI-only strategy enabled treatment of more patients and resulted in fewer population-level cardiovascular hospitalizations than PVI with adjunctive ablation strategies. Although adjunctive ablation modestly reduces atrial fibrillation, recurrence per patient, this benefit is offset by reduced procedural throughput and increased iatrogenic atrial tachycardias and flutters. Third, across all modeled scenarios, PVI plus strategies were consistently associated with higher total atrial arrhythmia burden and cardiovascular hospitalizations with no break-even point reached within realistic procedure durations. Next, patients not undergoing ablation owing to reduced capacity and treated with antiarrhythmic drugs contributed disproportionately to the overall arrhythmia burden and clinical events. These findings highlight the importance of evaluating AF ablation strategies beyond per-patient efficacy, incorporating system-level constraints and healthcare capacity. Hybrid pentaspline pulsed field and radiofrequency ablation for left atrial mitral isthmus block, acute and long-term outcomes by Dr. Ioannidis and colleagues. First key finding, despite the suboptimal durability of mitral isthmus lines created by the pentaspline pulsed field ablation catheter, as suggested by emerging clinical evidence, the implementation of a hybrid ablation technique offers a superior alternative, markedly enhancing the efficacy of achieving transmural block. Next, epicardial radiofrequency ablation within the coronary sinus remains a critical requirement in nearly half of the cases to ensure acute procedural success and sustained conduction block. And third, in the limited number of patients requiring repeat procedures, the mitral isthmus lines exhibited high rates of chronic durability, particularly when a dual energy strategy was implemented. A practical lead exchange technique without additional venous puncture in the era of conduction system pacing by Dr. Onishi and colleagues. Key findings are first, upgrades from right ventricular apical pacing to conduction system pacing may require lead replacement, but additional venous puncture can introduce procedural risk. This report presents a practical technique that preserves venous access without additional puncture. Second, the technique uses a retained intravenous cannula sheath placed between the outer insulation and the conductor coil of a non-adherent transvenous lead, allowing subsequent guide wire insertion and delivery of a long guiding catheter. A practical advantage of this approach is that it enables direct transition to long delivery systems and may allow temporary unipolar backup pacing when structurally appropriate leads are used. And finally, although 18-gauge cannula retention was difficult or unstable in some lead models, all evaluated leads accommodated a 20-gauge intravenous cannula. When a 20-gauge was required, the technique could be completed with a 0.025 in guide wire. Does acute response to stellate ganglion block predict the success of cardiac sympathetic denervation? Preliminary evidence by Dr. Doundalakis and colleagues. The first key finding is that this study shares the results of our experience with cardiac sympathetic denervation at a single high-volume European center. Freedom from ventricular arrhythmias was achieved in 60% of the author sample. In patients with non-ischemic dilated cardiomyopathy and refractory ventricular arrhythmias, a positive response to stellate ganglion block may predict sustained benefit from cardiac sympathetic denervation. Third, this perfect concordance in our small non-ischemic dilated cardiomyopathy subgroup supports the concept that stellate ganglion block can help identify cases in which sympathetic hyperactivity is a dominant driver amenable to permanent denervation. And finally, in contrast, non-responders to stellate ganglion block may have alternative mechanisms less likely to benefit from cardiac sympathetic denervation, highlighting the potential value of stellate ganglion block as a minimally invasive selection tool. Well, thank you for listening to the August podcast. I think we had a great lineup this month, and I will look forward to speaking to you again next month when we do the September podcast.